joint session and to continue the collaboration between our two societies. So we are going to speak about the adenomyosis and the infertility. I would like to thank all the people in my department who work with me to take care of the patient and to perform clinical and science research. So the mechanism which can explain the infertility in cases of adenomyosis are numerous. At the level of the endometrium, you can have also associated endometriosis. You can also have abnormal uterine transport, tubal occlusion, or distortion of the uterine cavity, and problem of contraction with uterine peristalsis. The impact of the adenomyosis on the fertility is very important. And you can see that when you look at the results of the ART, you have a significantly decrease of the live birth rate and a significantly increase of the miscarriage. And in the department, we look at the results of the ART for the endometriotic patient with or without associated adenomyosis. And you can see that when we have no associated adenomyosis, the results are significantly better than for the patient with associated endometriosis. And when you perform multivariate analysis, the independent factors which are associated with the fertility results, one of the three parameters is always the presence of an associated adenomyosis. In another study in India, they clearly demonstrated that you have exactly the same result in the ART for the tubal occlusion or for the endometriotic patient, but when you have an associated adenomyosis or adenomyosis alone, the fertility rates are significantly decreased. As it was previously said by Mariona, endometriosis is an heterogeneous disease, and you have three main phenotypes: the focal lesions, the diffuse, and the adenomyoma. And we demonstrate that there is a relationship between the phenotype of the adenomyosis and the infertility. And in our experience, you can see that the infertility is significantly associated for the patient with isolated focal adenomyosis. So how to manage the patient with either infertility or desire of pregnancy and adenomyosis? Is it necessary to perform the surgery or the ART? When you look at the surgical treatment concerning the adenomyosis for patient and infertility, it's amazing, but 90% of the paper came from Japan. So when we look at the results of this difficult surgery, one of the main surgeons in Japan for the adenomyosis surgery is Professor Osada. He performed an interesting series of 100 patients. And you can see that the fertility result seems to be satisfactory because he obtained 60% of pregnancy. But what is very interesting when you look deeper in the analysis is that 75% of the pregnancy after this difficult surgery are obtained by the IVF. And all the delivery are performed by C-section. Another paper from Japan are exactly the same results. Kishi, who know very well the problem of the adenomyosis, demonstrate that you have no place for the surgery when the patient are more than 40 years old. And for the patient less than 39 years old, you can see that the fertility results are quite less, 30%, and 50% of the pregnancy are obtained with the help of ART. But more interesting in the paper of Kishi is the parameters which are correlated with the chance of pregnancy. He demonstrated that if the patient is older, the fertility result will be less. It is normal. And what is very interesting, he demonstrated that when you have a posterior focal adenomyosis in the uterine wall, you significantly decrease the chance of pregnancy. And this is very important for the strategy, because in our department we look at the deep endometriosis according to you have or not an associated posterior focal adenomyosis. And we demonstrate that when the endometriosis, deep endometriosis is associated to these focal posterior lesions, the deep endometriosis is significantly more severe disease with more multifocality, more intestinal involvement, more multifocality in the intestinal wall, and more associated adenomyosis. And this is also important because the team of Paco Carmona demonstrate clearly that when you perform the surgery of the deep endometriosis and you have an associated adenomyosis in the posterior uterine wall, you significantly increase the risk of complication of the surgery. So the pregnancy are obtained with the IVF. The surgery is difficult, and when you have a focal adenomyosis, the disease is more severe. So we need to take care of that. Because the surgery is difficult with a risk of hemorrhage, transfusion is significantly more important. And when you look at these meta-analyses from Brazil, when you look at the conservative management of the adenomyosis and infertility, that's true that you obtain 30% of the pregnancy, but the rate of spontaneous pregnancy after the surgery alone is less than 20%. You have exactly the same message from Paolo Vercellini in Milan, who look at the results of the fertility after the radical surgery for intestinal deep endometriosis, and you can see that if you have an associated adenomyosis, because of the adenomyosis, the disease is more severe, more difficult, and with a higher risk of complication, you have significantly less chance of pregnancy. And the third parameter, which was demonstrated by Kishi, which has an implication concerning the fertility results, is the fact that before the surgery, the patient has previous history of IVF failure. And when we look at the patient less than 40 years old in this series, with previous 2 IVF failure, you can see that the chance of pregnancy is 40% of the patients, and the majority of these patients, 90%, 86%, are obtained with the IVF. And in the department, because of all these results, we decided in some selected cases to perform the ART without performing before the surgery. And in this selected series of patients with unoperated intestinal deep endometriosis, you can see that after 3 attempts of IVF, we obtained excellent fertility results for this patient without surgery. And what is important in this series of 100 patients with intestinal endometriosis is that in 73% of the patients, they have an associated endometrioma, and more important today, 90% of these patients, they have an associated adenomyosis. And you can see that it's possible to obtain a cumulative rate of pregnancy only with the IVF in more than 60% of the patients. So the place of the ART for this patient is crucial. So how to perform the ART? When you have an associated adenomyosis, you will decrease the chance of pregnancy. We precised that previously. But according to the protocol you use, if you use some ultra-long protocol, you will significantly increase the chance of the ART results. And this was confirmed by these large series performed in China, who demonstrate clearly the advantage of the ultra-long protocol. In this series of the meta-analysis performed also in Brazil, you can see that if you have a shorter protocol, you have less chance of pregnancy, and if you use long and ultra-long protocol, you not only increase the chance of live birth rate, but you decrease the risk of miscarriage. And in these meta-analysis, Vercellini demonstrates clearly that you have better fertility results if you use long-term protocol for desensibilization. The impact of the generation analog is not only on the fertility results. When you look at the rate of miscarriage for the patient who is without adenomyosis, the rate of miscarriage is significantly more important when you have an adenomyosis associated, and you will significantly decrease the risk of miscarriage when you use the generic analogs. So concerning the protocol, you will use the long protocol with the generic. Now, how to perform the transfer? You perform a fresh transfer or a frozen transfer. In the department, a few years ago, you look at the results for the patient with endometriosis according to we perform fresh or frozen transfer. And you can see that the results are impressive, are significantly better for the patient with a frozen group. But when we go in details in the analysis of the results, you can see that each time in blue we use the frozen transfer, we significantly increase the chance of pregnancy, but the benefit of the frozen transfer is significantly more important when we have an associated adenomyosis. So I think that perhaps we have not to perform a freeze-all techniques, but if we have endometriosis and adenomyosis, it seems to be a very good indication. And this was confirmed in China recently, last year, who demonstrate clearly that when you perform the frozen transfer, you have significantly more chance of pregnancy. And the paper is submitted and we are performing the correction, and when we look at the result of the freeze-all strategy, we significantly in the department increase the chance of pregnancy. This was also demonstrated in China 10 years ago by NIU, who clearly are in favor of frozen transfer with before preparing the endometrium with HRT. So to conclude, I agree completely with Mariona, previous speaker, who demonstrated clearly the key place of the radiology in the management of the patient with adenomyosis. You will have the diagnosis without surgery because you perform correctly the imaging process, and the transvaginal ultrasonography must be the first-line imaging technique. Very interesting and very important in the management of this patient. You will know also, only with the imaging, that if you have or not an associated endometriosis, and the management will be completely different. And what is interesting, you must check to know if you have or not a focal adenomyosis, because it seems that the focal adenomyosis is a marker of the severity of the deep endometriosis. That wants to say that you will have a risky surgery. And it seems that the fertility results are correlated to the presence of a focal associated adenomyosis. So if we try to look at the management of the patient who want to be pregnant with an adenomyosis, we change our management in the department during the last 5 years. As it was previously said, we perform a non-surgical diagnosis with the transvaginal ultrasonography plus or less the MRI. And at this moment, we have one question. Is it a problem of hemorrhage, HMB, and you have to take care also of the iron deficiency. And before to treat the pain of the patients, you also have to take care of the necessity or not to have a treatment for the iron deficiency. One quick question which is not resolved before to decide the strategy, is it necessary to perform to this patient a fertility preservation? And this patient, when you perform the diagnosis of the adenomyosis, she don't want to be immediately pregnant, so you prescribe the medical treatment. You don't perform the surgery. And the key question, the key moment in the strategy, in the management of this patient, is the moment when she wants to be pregnant with or without infertility. And for this patient now, after discussion, information, we propose systematically to perform an ART without performing the surgery. And you see that we obtain very, very good results for this patient. It is exactly the same what Garcia Velasco performed 20 years ago, and he performed ART without performing the cystectomy of the endometrioma. And you obtain the baby with the ART. You prescribe the medical treatment. And when she's 35, 38, she has the baby. She wants to stop the medical treatment, you will perform the surgery of the adenomyosis. And you will perform a unique surgery, you will remove all the deep endometriotic lesions, and you will perform an associated hysterectomy because you have the baby. So you will have no recurrence, no pain, no hemorrhage, and no medical treatment. And you can be sure that the patients are very satisfied. And I never do that before, but now we perform hysterectomy for patients for 30 years old with severe deep endometriosis and hysterectomy. And I invite all of you to come in Geneva in next April for the 10 meetings of the CEUD, and I hope we will continue to share and to be between friends to take care of the endometriosis and uterine disorder. Thank you very much.
Thank you, Professor Charles, for this nice presentation.